Friends, welcome to the Certificate Course in Obesity Prevention and Management CCOPM. This is a joint initiative of the Chalaram Diabetes Institute, the Public Health Foundation of India, the World Obesity Federation, and the Strategic Center for Obesity Professional Education. I now present Module 1, which talks about the introductory aspects of obesity. The learning objectives of this module are to understand the definition and diagnosis of obesity, to gain an overview of the epidemiology of obesity and its comorbidities, to understand the physiology of weight balance and the pathophysiology of obesity. These are the subtopics of this first module. Section A will look at the definition and classification of obesity. Section B will cover the complications and comorbidities of obesity. Section C will look at the epidemiology of obesity. Section D will look at physiology of weight balance. And Section E will look at the pathophysiology of obesity. So let's look at Module 1, Section A, the definition and classification of obesity. Now, let us begin with the introduction. Obesity is a chronic disease characterized by excess fat or adipose tissue. Obesity is a serious risk factor for complications and is also associated with an impaired quality of life. Obesity is a common problem with a worldwide prevalence. It is a chronic disease and is caused by a combination of both biological and environmental factors. This slide shows you the definition of obesity. Simply put, obesity is the excess accumulation of body fat. Currently, in clinical practice, obesity is defined by measuring the body mass index. The body mass index is calculated by dividing the weight in kilograms by the square of the height in meters. Internationally, a BMI cutoff of more than 30 kilograms per meter square suggests the diagnosis of obesity. This slide shows you the classification of obesity and overweight. In the row on the top, you look at the various categories. Below that, you find the various categories such as underweight, normal weight, overweight, obesity class 1, class 2 and class 3. The second column shows you the BMI cutoff. You can see that less than 18.5 kilograms per meter square is considered underweight. Normal weight or normal BMI is considered as a BMI between 18.5 to 24.9. Overweight is a BMI of 25 to 30 kilograms per meter square, or rather 25 to 29.9 kilograms per meter square. Obesity class 1, 30 to 34.9. Obesity class 2, 35 to 39.9, and obesity class 3 is more than 40 kilograms per meter square. In the middle column, you will see the Asian BMI cutoffs. Now, these are different from the global BMI cutoffs, and these are the Asian BMI cutoffs endorsed for Asia Pacific populations by the World Health Organization. And you will see that these values for diagnosing obesity are at lower levels of body mass index in Asians compared to the global population. In other words, people from Asia are at a higher risk of obesity-related complications at lower levels of BMI, and that's why their BMI cutoffs are lower. I will just pause for a few seconds so that you can note down the differences between the global BMI cutoffs and the Asian BMI cutoffs. In the column on the extreme right, you will see the clinical importance of the BMI or the BMI categories. You can see that wherever the category is underweight, the risk of weight-related illness is increased, which means people with a lower BMI also have an increased risk of morbidity and mortality. In normal weight, if you were to consider the risk of weight-related illness as normal, in overweight, it is increased. In obesity class 1, it is high. In obesity class 2, the risk of weight-related illness is very high. And in obesity class 3, or the international BMI cutoff more than 40, the risk of weight-related illness is extremely high. Now, just to put things into perspective, let's look at a case. This is a 35-year-old gentleman who exercises regularly. His body mass index is 32 kilograms per meter square. He is well built and looks muscular. So obviously he doesn't look obese. That's a point which I wanted to highlight, because whenever a patient walks into a doctor's clinic, or whenever a person walks into a doctor's clinic, with one look, the healthcare professional can make out if this lady or gentleman is obese, because you have an idea of the fatness. But look at this 35-year-old gentleman who exercises regularly, has a BMI which is high, 32 kilograms per meter square, but he's well built and muscular. So obviously he does not look obese. Hence, is BMI always reliable for obesity is a question we are asking. So this slide shows the limitations of BMI measurement. Muscle is denser than fat. Hence, muscular people such as weightlifters often have a healthy weight, though their BMI is classified as obese. Ethnic groups can also affect risk. Example, adults of Asian origin may have a higher risk of developing health problem at BMI levels below 25 kilograms per meter square. So BMI is also not a reliable assessment of obesity during pregnancy. I just showed this case to highlight that BMI does have its limitations, especially in short, stout, stocky, muscular people, where BMI may overestimate the degree of fatness, and looking at BMI alone may misclassify a very muscular person as being obese. So another way, as the slide shows, is to do a body fat interpretation by imaging. BMI does not describe the body fat distribution. The body fat distribution is associated with chronic disease. The truncal and visceral fat is associated with metabolic abnormalities at various BMI levels. The accumulation of leg fat as opposed to abdominal fat, the accumulation of leg fat is associated with a largely favorable metabolic profile. The total body fat measurement is also associated with all-cause mortality. Dual energy X-ray absorptiometry, or DEXA, could be a useful test because it quantifies the fat. CT scan or MRI scan can also be used. So these are all different ways of imaging and different ways of body fat interpretation by imaging. Now this slide introduces you to dual energy X-ray absorptiometry, or DEXA. You can see the picture of the caregiver, you can see the X-ray arm, you can see the table, you can see the person lying down, which is a process of the bone densitometry scan, which is also used to quantify body fat. So the DEXA utilizes two energies of X-ray. The difference in the total absorption between the two can be used. Software will subtract out the absorption by a particular tissue. So this leaves just the absorption by the bone or the fat, as the case may be. The fat mass divided by the total mass into 100 will give you the fat mass percentage. That's very crucial to understand the fat mass percentage, because as I said, a person may have a high BMI but may be muscular, and that person may actually have a low body fat mass percentage. So this is the enhanced data, the body fat mass percentages in total mortality. This is a study that included 9,471 participants more than or equal to 20 years, and they were free of major chronic diseases at baseline. Information was obtained from the National Death Index, a mean follow-up duration of 8.8 years. The body fat mass percentage for the whole body and each region was calculated, and the fat mass divided by the total or regional mass times 100 was calculated. In this study, as you can see, if you look at the highest quartile, you will see that highest total body fat content or quartile is associated with increased total mortality in the US adult population, which is an enhanced population. You'll also see that truncal fat, if you read the paper, it will also be evident that truncal fat, higher truncal fat, also associated with high mortality. So this is just to show you that body fat percentages correlate with mortality. Let's look at the limitations of body mass index and total body fat. Now the body mass index and the total body fat really do not measure central obesity. Central obesity, which is the fat in the visceral tissue as well as the subcutaneous abdominal fat. Central obesity has been linked to adverse cardiometabolic health as well as chronic disease. So that brings us to a simple measurement of central obesity, which is a waist circumference and the waist hip ratio.